Good evening, everyone. My name is Catherine, and I am a clinical lab consultant with WAVE.
And I'm Shelby. I'm also a clinical lab consultant with WAVE.
Welcome to tonight's webcast titled Orthok and Myopic Undercorrection, When You Miss the Target, with Dr. Ken Mahler.
Hello all, I'll be speaking with you later.
This evening, in addition to Dr. Mahler's cases, Shelby and I are also going to present a couple cases that we have received through WAVE Clinical Support. And again, tonight our speaker is Dr. Ken Mahler. Dr. Mahler earned his doctorate at the Illinois College of Optometry and is currently in practice in Fort Lauderdale, Florida. His practice is devoted to orthokeratology, as well as providing visual rehabilitation for the irregular cornea. And he's one of the foremost WAVE contact lens designers in the world and lectures extensively on custom contact lens design and provides clinical consultation services. He's a fellow in the American Academy of Optometry and a fellow in the International Academy of Orthokeratology and a diplomat in the American Board of Optometry and a fellow in the Scleral Lens Society. So on behalf of WAVE, thank you for being with us tonight, Dr. Mahler, and also thank you to everyone who is attending. So we can just jump right in. I'm going to go ahead with the first case. And again, this is a post-dispense case that we received through clinical support. This is a fairly straightforward case, and we ended up making minor modifications just to start for this patient, but I thought it showed the importance of obtaining over-refraction with lenses on at follow-up visits, and then also reinforcing that patients are bringing lenses to each of their visits. And so this is the email case submission that we received. It's for a 16-year-old patient. Lenses are about a year old, and you can see that the starting prescription is there, and then we do have some residual myopia in the post-treatment RX. And then there is some minus coming through in the over-refraction with the lenses on as well. The notes stated that the patient had been successful in Orthok in the past, so we know they can achieve 20/20 vision. They have complaints of fading vision, and then at the most recent follow-up, presented with reduced visual acuity. And here are the difference maps that were sent. We can see that the treatment zone is well centered in both eyes. Reverse zone is pretty well defined. The treatment zone is maybe just a little patchy. And here are the fluorescein images that were sent in. It may be a little hard to see, but the diameter does look adequate. Both lenses, you can see, do have a bullseye pattern. And there are some insertion bubbles in the reverse zone there. The edges are maybe just a little bit steep, but overall it does appear to be a good fit. So for this patient, the thought process here is that because they have been successful in the past, as the years kind of going by, vision is fading and we have that residual myopia coming through, there's most likely myopic progression. So usually our normal process when lenses are coming up to being a year old is to start with a duplicate set of lenses, have the patient wear the lenses for 2 to 3 weeks and follow up. And we recommend that just because a lot of undertreatment or complaints of fading vision can be due to lens age and warpage. And a lot of times a fresh pair of lenses can really take care of many of those issues. And then if changes do need to be made after that point, the data from a fresh set of lenses is usually a little bit more reliable and can keep us kind of from chasing our tail in a sense when we're making modifications. But for this patient, the over-refraction in the post-treatment prescription indicated that we needed to modify just to give them more treatment. They have more myopia in the post-treatment refraction than we usually like to see. And the over-refraction didn't really sound like lens warpage. So for this patient, we decided to start by flattening the base curve in both lenses based on the over-refraction information that was given. And this is just showing the modifications made in the new software. So we can modify the base curve in the new version 2 ways. We can do it by moving the orange control points in the tear film graph, but we do typically use the modification area, which is in the bottom left corner. And you can easily do that just by selecting base curve and then choosing the amount that you want to steepen or flatten the lens in diopters. Typically when we're doing that, the over-refraction that we're aiming for is +0.5 to +1 with the lenses on. So for this patient, for the right lens, we ended up flattening by 3/4 of a diopter, and the left lens was flattened by 1/2 diopter. And this is the follow-up response that we gave to them. We have not had anything else come through for this patient, so we're going to assume that they're doing well at this point. Based on the topography, if they did come back and they were still having complaints after wearing the lenses for 2 to 3 weeks, the next step in this case would be most likely to decrease the sag at the reverse zone and give more push centrally to kind of clean up the patchiness if that was still coming through in the treatment zone, just by bringing the base curve a little closer to the cornea. We would also consider decreasing the sag at the alignment zone if the edges appeared steep, but the centration looked very good for this patient, so I would try to make that change last just so that we are not flattening the periphery too much and potentially causing some decentration, just being mindful that the patient is of driving age and we wouldn't want to induce any glare or flare for this patient and just really maximize their vision as best we can. And that is it for me. I am going to go ahead and pass it over to Shelby. Thank you.
Okay, so I'm going to stick with the under treatment trend. So this was another email case submitted to clinical support. The patient is 15 years old. The lenses were 2.5 weeks old. We had a low myope here. Right eye was minus 175. Left eye was minus 175, minus a half at 145. The unaided VAs were 20/20 minus 2 on the right eye and 20/25 minus on the left eye. Over refraction was plus a quarter on the right and minus a quarter on the left eye. And they just gave the post-treatment RX for the left eye, which was minus a half. So just a little undertreated. The doctor also sent a note. Patient, he wants to change the left eye only for the patient. They have discomfort with just the left eye and a little bit of residual myopia, but the fit looked good. So the doctor did send over the baseline map, the post-treatment map as well. So I was able to create a difference map. We can see in the difference map here that we have really great centration, which is good. The only issue is we have a little bit of a patchy treatment zone here, which we can easily fix, and that's probably the culprit for maybe that little bit of under treatment that's happening. So he also sent over a fluorescein video, which was great. Remember the patient mentioned that there was discomfort with the left eye. So here we can see that the lens is really tight and steep in the periphery. So my assumption was that this was probably the reason for the patient feeling uncomfortable with the lens. So again, my evaluation was, like you saw in the video, there should be, more fluorescein right at the edge there. It looked really tight and too steep. We had the patchy treatment zone in the difference map. And then if you remember back looking at the over refraction, the right eye had the plus a quarter over refraction, which is good. That's what we want between plano and +1. But the left eye had the minus a quarter. So that's one thing that we can change. We know we have room to flatten the base curve and get it maybe up to that plus a quarter like the right eye was. So we'll go through the modifications really quick. The first thing that I will change is to flatten the base curve. So I know Catherine touched on that a little bit, but I'll show you how to do that again as well. So we'll go to the little toolbox down here. We'll just go to the base curve, and the patient again had the minus a quarter. So I just flattened it by a half diopter. This will bring it to hopefully about plus a quarter like the right eye. And that will also help take care of a little bit of that under treatment. You can see it changed the power in the base curve there in the software. So the next thing was the patchy treatment zone. Sometimes with under treatment, when you can see this will work for the specific case, you can do a reverse zone decrease and flatten the base curve if there's room for that. So for this one, I'm not going to do a lot to the reverse zone. I'm only going to do 5 microns, and I'm decreasing that just to help with that and the base curve. We should knock out that minus a half under treatment. And you can see that when I made that change, it also loosened the pink, the periphery, which is what we wanted because it was so tight. But we also, I think, need to do a little bit more because, it looked pretty tight on the eye. So I just went ahead and went to 2x, and then I'm just going to click up on that again. I don't want to loosen it too much. It had great centration, but we just need a little more tear exchange in there. And then final thing was just click around the meridians, and then I think that was it. Those were the changes that I made. So, you know, it's always important to create a difference map. When you have the baseline and the post treatment, you can see, if you remember back to looking at the topos, the difference when you actually created the difference map versus just the post treatment. So it's important to really see what's happening at night with the lens on the eye. Also, taking the over refraction on top of the lenses is very helpful. We use this to determine if you know, we have room to flatten the base curve. And like I said, we use it a lot as a kind of a combo modification. And then finally, fluorescein videos or pictures are always very helpful, especially if you're utilizing clinical support. It can tell you a lot. And in this case, it just helped us with maybe figuring out the discomfort for the patient. So that is my case. That's it. I'm going to pass it over to Dr. Mahler, and he's going to review some cases with you.
Okay, thank you guys. Let me get my screen set up here on my presentation, and then I will show my screen. Yes, and show my screen. And hopefully you're seeing my cover slide right now.
Yep, we can see it.
Fantastic. Okay, let's move on as well. And let's get into tonight's topic. So undercorrection on the myopic ortho-K patient, why does that really happen? Well, there are a lot of reasons to why that happens, and that's what I'm going to go through on my part of the presentation tonight. First, we started with the wrong prescription. We just targeted the wrong RX. The source topography might be tainted, and so we're designing up a lens on bad data, and of course we'll end up with a bad result. We've designed up the incorrect lens, and of course that's not going to provide us the full treatment unless that happens purely by accident, which almost never is the case. Incorrect lens usage, that's on the patient's side. Maybe they're wearing the lens during open eye activities, or incorrect wear time, and they're not getting the proper treatment time. Also, solutions play a very large role in how these lenses work, and I do want to talk about thick solutions as well as reaction to some of the solutions. And then also a pseudo undercorrection due to epithelial disruption. And that can happen because the lens is designed too tightly, where there's excess lens sag, such as there was in the very last case that Shelby just presented there, or it's too loose, you have inadequate lens sag, or the plunger and it's mechanical that's causing this epithelial disruption, leading to what apparently is an undertreatment. So I'm going to go through each one of those a little more detail right now, starting with the incorrect prescription targeted. So we have an inaccurate refraction. Again, I'm assuming that everyone can refract out there, but there are reasons that the refraction may have been inaccurate right to begin with. Binocular vision issues. This is a real big problem. When you do orthokeratology, you will change accommodative function, and you will also change Virgin's function, and as a result, you may be uncovering some binocular vision issues, and this ends up causing an apparent undercorrection, when in fact the heart of the problem is binocular vision, and it just wasn't tested for initially. Transient myopia. You may be dealing with a transient myope, and as a result, you've targeted the incorrect prescription to begin with. And again, you may have a undertreatment or even an overtreatment as a result of that. All right, so let's go to the source data tainted. Operator error. Now, I covered a lot of this in webinar 1. I'm just going to go over a quick review of it here, but there's actually a lot more of it in webinar 1. So if you can go back to webinar 1, I really did go a lot more in depth into this particular topic. But here I've just summarized some of what I had covered there. So here you have a couple of source topographies, and we can see that in addition to the topographies, there's an awful lot of lid in the picture. When lids are in the picture, you end up destroying the reliability of the topographer's ability to get good data centrally. So that absolutely can play a role, and it can throw off your entire design as a result of that. Second, we have this particular case over here, and we look there, and on the right eye, you can see that the lid's definitely in the way, but the left one, it's actually not that bad. It looks like the lids are pretty well out of the way, and we have some pretty good central data. So you might be saying, well, what's wrong with that? Well, if we take a look down on this next one, over here, we have actually pretty decent coverage there. The problem is this is the exact same patient taken at 2 different times. So what happened here is that the capture was done inappropriately, and we could see that the capture on the top is showing that the cornea is considerably steeper than the capture on the bottom. And if I remember correctly, I think this this case was missed by about 3 diopters because of the fact that the original source topography was in error there. All right, here we have another topography, and that one looks pretty well covered. We could argue that the lids are a little bit in the way. The one below it, again, we have good coverage, but once again, this is the exact same eye taken a couple of seconds apart. And you can see that the map that's been processed by the topography software is very, very different. On the top, it appears that we have considerable steepness below the central horizontal line. And then on the bottom map, it appears that the cornea is very steep on top. And so if you're getting this kind of data and you're designing a lens from this, this is a problem because you're going to design the lens incorrectly. Here on the Penacam capture, what was done wrong here is if you take a look in the upper left corner, you could see that the patient was looking off to the right as this was captured. Well, that really throws off all the elevation data. And once again, you will end up designing an incorrect lens. So it's important that the operator is paying attention to what the patient is doing during all of these captures. Very lastly, this capture is actually a pretty good capture, and you can see the lids are totally out of the way, and the eyes look fairly similar to each other. In fact, they're a little too similar. We have a little blip there where it's both steep and flat within that circle on the right and left eye. So what do you think happened here? Well, I don't really think that the patient is identical in both of those areas. What really happened is it was a calibration error. And when the topographer was originally calibrated, it was probably some debris or something like that on the calibration sphere. And that's what's causing the topographer to render that same error on both eyes. So these are all very, very subtle types of sources for these types of errors to creep in, and especially if the doctor who's doing the lens designing is not taking the topography and you're getting this as data handed to you after the fact, you could easily miss that the topography is tainted. So it's very important to be very critical of this data before you start designing lenses from it. All right, let's move on. Current contact lens wear, GP or soft. A lot of people think soft lenses are innocuous. They're far from innocuous. They can really taint the topographical shape of the patient. And I did cover this a little more extensively in webinar 2. So if you're interested in getting more information about this, please go back and view that. But again, I brought the summary slide here. So here's a soft lens wearer, and you can see the capture is good, but we have a kind of an oddball shaped cornea there. After 2 months of no lens wear, and the reason it's 2 months is even 1 month this was not appearing normal, this is what this cornea looked like. And so you could see if you had taken the soft lens off and designed from that top map, you would end up absolutely in left field with your Orthok treatment, whereas the map down at the bottom is certainly much more trustworthy. Here is a GP corneal lens, and once again, the cornea looks a little strange. After 3 weeks of wearing a GP for rehabilitation purposes, and this is a case, of course, that I did, you could see that the cornea looks a whole lot more normalized. And so this brings 2 very important points to the table. Number one, all GPs do not necessarily cause corneal warpage. And number 2, they can wear a GP and have a normal looking cornea. but it's important to be able to recognize when the cornea is being tainted by the GP wear. Number 3, this was a scleral lens, and of course the take-home message that I consistently hear is scleral lenses don't do anything to the cornea because they're not on the cornea. Yet, taking this scleral lens out of the picture and putting a corneal lens into play for 8 weeks, this is what the cornea looked like. So scleral lenses are not innocuous and soft lenses are not innocuous. And GP lenses don't have to be nearly as nasty to corneas as they typically are thought about. So again, if you're critically evaluating your data prior to designing the lens, and they've been wearing a lens, you even have to be more critical. Is there something that's being introduced because they're wearing a contact lens? All right, know your instrumentation. This here is on a Penacam scan, and this was done on a patient that I did not see, nor did I design the lenses, but the patient came in to see me. This is a 41-year-old here, and what we can see is that the Penacam reported a white-to-white measurement of 12.4 millimeters. We could also see that the scan quality is good. And furthermore, we can see that we actually have good map data out to 12 millimeters that was real. It was really captured out there. One of the nice things that the Penacam does that's impossible to do on placido disc-based platforms is that we really can get data all the way out to the very edge of the cornea, and it's real data, which helps in terms of designing lenses. So initially, this all looks actually quite good. Now, here was the lens design, and again, I didn't have anything to do with this lens design, so I would have done a couple of things a little bit differently, but that's not really what we want to talk about here. But I do want to bring them up, some of these points. We could see that the astigmatism was averaged, which typically I would not do on an Ortho-K case. We could see that that white-to-white measurement was brought into WAVE as 12.4 under the HVID. We can also see that the chosen lens diameter was 11.8 on a 12.4 cornea, and that actually is a pretty good choice there. Center thickness is 25. That's probably a little thicker than I would have designed, and the edge thickness is 0.20, which is actually thinner than I would have designed. It was designed in a tangential mode, which I do not do. I design an axial mode. And furthermore, this was a freeform design lens, which again, I typically would not have designed that on this particular eye, especially looking at the shape of the eye. A GSIM lens would have been perfectly fine for this. And although you can't see it, prism was added to this, which again, I would not have added to the design. So although I have a lot of differences in my design approach than was done here in this case, I'm still presenting the case. And you can see it's a -5 myope. Here is the treatment maps. I did this in my office. That was the original source map that was used. And we could see the treatment map. And we can see it's well centered, but we have a fairly small treatment zone. Residual refraction was about a -0.5 diopter. So he was a little undertreated. We also could see on this difference map that the reverse curve is very broad. It's very wide over there. The patient was complaining of significant glare, and he's unable to drive at nighttime. It's absolutely off the table because he just doesn't have the vision to feel safe. When he was originally in, prior to starting, I am to also take these scout images, and you can see that here's the source map on the scout, and here's the treatment map when he came in at the same time that Penacam was captured. And what I want you to notice on here is a couple of very important things. I just summarized what we were just talking about: small treatment zone and a residual of -0.5 diopter. Here, I measured on his cornea his HVID at 11.72. Now remember, the Penacam reported the white-to-white as 12.4, so that's a considerable difference. We also can notice on this that the reverse curve treatment, I put those markers down in the middle of the reverse curve treatment zone, and you can see that it peaks at about 4.63, core to 4.63 millimeters. Now here's the lens design, and on the lens design, we could see that the reverse curve peaks at 5.6 millimeters. So the lens has its peaks of the reverse curve at a chord about 1 millimeter larger than we have the treatment peaks where those are peaking on the actual cornea. Take-home message here is white to white does not equal HVID. The 12.4 is what drove this to be undercorrected, and that was kind of like on that first case we were talking about. So if the diameter is too large, what ended up happening, which I saw on the dispense of this lens, is that the edge of the lens was right at the limbus. And remember, the lens design was at 11.8, and I have the HVID at 11.7 too. So when I looked at the lens on the eye, immediately I saw that the lens was too large. And I also told him there's more than likely we're going to end up undertreated, which in fact is exactly what we did. So the key here, since white to white doesn't measure HVID, is how do we measure on the Pentacam a better number for us to use to design lenses? So we could see here, the first thing I do is I'll decrease the contrast using it on this Scheimpflug image. You can see I've selected the 180 to 0, which is the straight across, because we're looking for the horizontal measurement. And you can see there I drew on there with the measurement tool, and we got a value of 11.7 from the white to white. So that would be the equivalent area that we typically would measure as the edge of the cornea, where we're turning into limbus, as though we were measuring it from the front of the eye, looking at it at the slit lamp. So it's not that the Pentacam is inaccurate, it's reporting white to white measurements, which are not the same as HVID measurements. And depending on how opaque the limbal transition zone is, that error can be significant, such as it was on this case. We had an error there of about 0.7 of a millimeter that we used for our design. So it's important to understand your instrumentation and make certain that you know all the nuances that are happening in the instrumentation. This particular nuance is on the Pentacam, where you have to be very careful about using the white to white measurement to decide how large the lens is. All right, incorrect lens design. Well, we just saw an incorrect diameter can cause a problem. Incorrect lens symmetry, for example, if freeform is just chosen and it's really not necessary. I've talked about this in another previous webinar about choosing the proper symmetry and why freeform is not necessarily the greatest thing to just default to, because it can actually create problems that you otherwise would not have had. Incorrect placement of the control points. This is another problem that I've seen coming up fairly commonly. A lot of the literature talks about if we're doing myopic management, especially on these kids, and we want to hold back the progression of myopia, decrease the optic zone. It's important to understand that the red control point is not necessarily the optic zone. And so if it's decreased and you place the control point in the wrong location, you can end up inadvertently causing a smaller and under treatment for your myopic case. So you have to pay very close attention to what's going on the back surface of this lens. Excessive sagittal depth outside the reverse curve, and that fairly commonly is just outside where the blue control point is horizontally. Fairly commonly, that'll be a little bit too much sag out there, and that tends to vault up the central portion of the lens. Sometimes it's even out at the pink control point, so you have to make sure that those are up high enough off the corneal surface so that you're not essentially tenting up the lens centrally. That's the location that I'm talking about. So be very careful in that location that it's not too tight out there and you have too much sag in that one location where it's landing. All right, incorrect lens usage. This is what I refer to as the broad category of user error. The user error means that you could have done everything right and they're still using it improperly and causing the undercorrection. So one of the places is incorrect application. They may be getting air trapped in the reverse curve. If air gets trapped in the reverse curve of the lens, I've seen a 2015 eye drop to 2400 in one night because of air trapped in the reverse curve. So the air is not necessarily a problem for the cornea, it's not necessarily a problem for the lens, but it's devastating for vision the next day. And if they consistently are putting the lens on with air trapped in the reverse curve, they will be consistently undertreated. Also, this is something I've noticed over the years. A lot of the new users with Ortho-K lenses might have trouble getting the lens on for whatever reason. They may have many failed attempts, and some of them might be at it for a half an hour. I've had some at it for 2 hours. If they are really attempting to get the lens on many, many times, it is not uncommon for them to come to follow-up undertreated. And I believe, I don't know this for certain, but I believe what is going on there is that in the many attempts that they're doing to get this lens on, they're absolutely destroying the tear quality of their eye. And as a result of that, the tear mechanics do not function properly under the lens once they finally do get the lens under the on their eye properly. And so if you get from their history that they're, oh yeah, I'm having a real tough time getting the lens on, it's taking me like a half an hour for the right one and like an hour for the left one, and they're undertreated, that may be the cause of why they're undertreated. Incorrect removal. So the lens now is maybe lightly bound or maybe not so lightly bound in the morning, and they're not checking to make certain that the lens is freely moving, and they go ahead and remove the lens. That's problematic as well. Open eye wear. This is a huge problem. If they're deciding to wear this lens during open eye activities, that actually takes your wonderfully designed Ortho-K lens and takes all those great curves that you put and pushes them all over the eye instead of where they belong. So if they wear the lens too long prior to going to sleep, generally speaking, 15 minutes is ideal. So within 15 minutes of the lens being on, you really want lights out, lids closed. You can swing that to 30 minutes, but more than 30 minutes is problematic. And so I try to tell them all, let's aim for about 15 minutes prior to you going to sleep is when I want you to put your lenses on. If you're one of these people who put the lenses on and then read your book for an hour and a half in bed, that is not acceptable. And so that's going to be a problem. Worn too long when they wake up in the morning. I don't know why they would choose to leave the lens on, but some of them will leave the lens on. The lens should be off the eye within 5 minutes of awakening. There's absolutely no reason to leave that lens on in the morning. Some of them decide they want to wear it intermittently during the day for whatever reason. Perhaps when they put the lens on, they have much sharper vision and they like that, so they'll go ahead and put the lens on for some open eye activity. That's a problem. Incorrect wear or treatment time. So we have both ends of the spectrum here. You have the person who is the poor sleeper. They sleep 2 hours at a time, so they'll put the lens on, sleep in it for 2 hours, take it off, and go about their day, and then they'll take a nap later on. That's a problem because you're not really getting proper treatment time of the lens. Excessive hours is typically a problem for the young kids. A lot of the young kids can be sleeping in lenses anywhere between 8 and 12 hours. The longer they sleep in the lens, the more likely you will have problems. And the reason for that is that typically, again, it's a tear film problem. They will start to accumulate garbage and debris under the lens. And as a result of that, whatever was done in the first few hours, which was wonderful, then gets destroyed by the fact that the lens now is not lining up properly because of all the junk that's sitting in the tear film between the back of the lens and the front of the eye. So excessive hours can sometimes be a problem as well. One intermittently or not during or not when they're napping. Intermittent wear, like that 2 hour sleeper, then they'll come back and they'll wear it again for another hour and then they'll take it off. And these are real problems. Or in the more global sense, they decided over the weekend they don't want to wear lenses, so they take the weekend off. Or, you know, every third day they decide they don't feel like wearing it. Any of this intermittent schedule of wearing can cause undertreatment. Now, as far as the napping goes, I'm not going to go into the details as to why that happens, but if they nap, you can almost be certain that they will be undertreated. There's a couple of theories that we have as to why that is, but anyone who's been doing Ortho-K for quite a few years typically will notice that if they decide to take a nap and they do not put the lens on, and let's say the nap is 2 hours, 2 hours later, the vision will be considerably worse had they just been awake for that same 2 hours. And so There's a lot of reasons as to probably why that's going on. I'm not going to get into that. Just be aware that napping can cause undertreatment if they're not wearing the lens during that nap. Incorrect solution usage. They're not cleaning the lens properly, so they're leaving debris on there, and again, that's a problem for the tear film. No Q-tip usage 1 time per week. That means that the reverse curve is accumulating garbage and debris, and that will slowly cause undertreatment. Typically at about the 2-month mark is when they'll notice that they're not seeing as well as they were earlier on. Or they decided to change the solutions you prescribed for them into whatever was on sale at Target that week. And again, solutions can be a big problem here, and so that may be a reason for undertreatment as well. Solutions, thick solutions for filling the bowl. I know a lot of you will use some thicker solutions. I do not. And the reason I do not is they really cause various problems. They hide or do some type of compensation for a bad design. I'm not trying to hide a bad design. I want to find out if there's something that's wrong with the design, and if using a thick solution, you will not know that because they really can hide the problems. It dramatically changes the hydrodynamic forces that are under the lens. Ortho-K is all about balancing hydrodynamic forces, and you're putting in these thick solutions that absolutely change that. It eliminates any of the micron nuances that you've put into your design. You've gone ahead and taken a lot of time to design up a great lens down to micron accuracy, and then you put in globs of some solution, and absolutely all those microns are gone, because that's not what they're actually wearing anymore, because you've trapped all this thick gelatinous mass underneath the lens, and that is not going to allow the lens to do the job it wants to do or it's supposed to do, and that typically will leave an undercorrection. It also has an unknown impact on the epithelium, and I put over here like ointment on healing. We know when you have an abrasion, if in fact you use ointment under for example, a pressure patch, which I can't imagine anyone does this anymore, it actually delays healing. Epithelial migrating and redistributing under an Ortho-K lens is very important. And if you've got thick solutions on there, that actually interferes with the normal physiologic changes that are supposed to happen as a result of epithelium doing what it's supposed to do. So I don't like thick solutions for that reason. It also absolutely will accumulate in the reverse curve no matter how good they clean the lens, and that decreases the effectivity of the reverse curve, or effectively drops it closer to the cornea, and as a result, you will end up with an undertreatment on that as well. Reactions to the solutions, they can be sensitive to the solution or an allergy, a flat-out allergy. The solutions do concentrate under an Ortho-K lens, kind of just like they do under scleral lenses. And so we have to be very, very careful, because again, that is changing the tear film dynamics underneath that lens, and we're relying on the tear film to cause the changes that we're trying to see. Lens materials may be affected by that as well, such as the anecdotes that we've had over the years from ClearCare. In case you're wondering about the ClearCare and you haven't heard that, ClearCare usage seems to cause premature breakage of lenses, gas perm lenses. There's no studies on that to support that, but I know on firsthand experience I've seen that happen, and I know several of my colleagues have had that happen as well. So be careful when the solution is the problem. Now, we talked about that epithelial disruption. If the lens is too tight, you will have excess lens sagittal depth out in the mid-periphery or periphery of the lens, and that can lead to malpositioning the lens, which alters the central treated area. And again, the central treated area is where you're getting your undertreatment from. The lens adherence or binding, once the lens is bound to the cornea, the hydrodynamic forces change. And as a result, typically, lens adherence or binding of the lens, typically you will overshoot. But if in fact the problem is causing too much metabolic stress for the epithelium, you'll end up destroying the central epithelium, and you'll see it doesn't look right, or they'll flat out stain when you bring them in the next day. And that can be from metabolic toxicity on the lens, because you're not exchanging anything. All of the metabolic waste is building up underneath that lens. Also, if the lens is bound or even just a little bit snug and they remove the lens in the morning, especially with the plunger, they can rip off all of that epithelium. It's for this reason I don't have any of my Ortho-K patients use plungers. If the lens is too loose, you have inadequate lens sag. That can lead to, again, a malpositioned lens, which alters that central area. And again, once that area centrally becomes, as we saw in the previous one, maybe a little patchy looking there, that can lead to an undertreatment. We also can just flat out disrupt the epithelium because the lens is sort of abrading the epithelium centrally because it's bouncing around underneath the lid. Or we just don't have enough support of the lens out peripherally. And so we're disrupting the lens because it's coming down too hard on the central cornea. And we did talk about the plunger used for removal. If there's any excess suction created underneath that plunger, underneath the lens from the plunger, they can disrupt all that tissue there and pull off epithelium along with the lens. So in summary, myopic undercorrection can be the result of many sources or any of these. And it's important to remember that a lot of these can't be fixed by changing the design. Since I'm assuming you are more experienced than the myopic orthokeratology patient you're treating, it's vital that if you end up undertreated and you have some myopic ametropia remaining, start your troubleshooting by questioning the patient to find out any sources of the problems that could have caused it, caused this problem, that the patient might be the culprit here, that user error I was talking about. Once user errors are eliminated, everything looks fine, then start a systematic approach to determine if any of the doctor side errors may have been introduced. For example, maybe the original data was tainted that you designed the lens from, or maybe the RX was wrong when you first started. I never change a design until all user errors have been eliminated and resolved, because the design will never fix any user errors. So it's important really to uncover any of those first and make sure those are all fixed before you start doing anything else to design. And with that, I'm going to conclude my portion of the lecture tonight. We can go ahead and shoot for any questions that have been popped up out there.
Thank you so much, Dr. Maller. I do have a few questions ready for you. Box on your screen for questions. Feel free to submit those. And if there are any that we don't get to, we can follow up via email as well. And I have the first question if you're ready.
Yes.
Okay.
Go ahead.
And what are your thoughts on using Ortho-K for myopia management for patients with a plano refraction or at about a -0.5?
So I'm assuming now you're talking about the young child who may be at plano, but you're measuring axial length and it's large, and maybe they're 5 years old and you know they should be hyperopic. So you've already identified that they've really fallen off the bus. They are progressing. They just haven't gone past plano yet. My feelings on that are absolutely wonderful. By all means, if you can get that across to the patient, good luck. I'm sorry, to the parent, good luck. I think that would be a very, very hard sell because number one, I don't think there's enough general awareness out in the public yet for them to be receptive to that. I mean, think about that from the parent side. So you mean my child is 20/20 and he has no prescription, but you want to put him in a lens every night for the rest of his life? Yeah, that's a tough one at this stage because I don't think that the general public has enough awareness. From the clinical side, I think that absolutely is the goal that we should be striving for, but I think it's going to be a few more years before we can get that out there. Now, as far as the -0.5 goes, I think that's an easier sell. And I've done those cases, and I think that you absolutely should step up on that because the myopia is already showing. And if it's showing, I think the conversation is a little bit easier with the parents.
Yep, that makes sense. And the next question, you mentioned calibrating topographers. How often do you recommend calibrating the topographer?
I can tell you I calibrate my topographer every day before I start work. In fact, one of the things I do, because I do still use my Scout on occasion as well, but when I do my Pentacam scans, I actually have to unplug my computer from the Scout to bring it over to the Pentacam, because I'm using a laptop for both. And when I bring the laptop back in and it's next to the Scout, I recalibrate it again. So my Scout gets recalibrated every time it's turned on, as well as every time it gets replugged into my computer to make certain that everything is perfect there. The Pentacam I will calibrate every time I come in the morning to start work that day.
Okay, great. And the next question is regarding Prism and Ortho-K lenses. Do you recommend using it, or is there a time when you do add Prism to your lenses?
Never. I don't
Okay.
understand I don't understand the logic behind Prism in an Ortho-K lens. It's under a closed lid. You would have to show me how that does anything to help whatever you're trying to achieve with Prism. So I would absolutely not put Prism in any lens, not for Ortho-K.
Okay. And the next question is there an issue for using freeform for all Ortho-K lens designs, or is that okay?
No, it is not okay. Absolutely not. If you use a freeform design lens, it looks really pretty on the screen and you think you've done a great job in designing a lens, but how it's going to perform on the eye is another different story. For example, if you have, let's take two principal meridians, steep and flat meridian out in the periphery, are different by maybe about 25 microns or so. 25 microns on the wave screen is more than a third of the way up on the screen. So if your lens is not aligning with the steep and flat meridian properly there, what you will see is the black line in relation to the green line is going to be about a third of the way up on the screen, and that may not sit very well with you. You may think, oh my gosh, that's really not aligning how I want it to, or it's not going to sit down properly, or it's not going to create the seal, or it's going to be uncomfortable, or whatever you're thinking. So you go ahead and hit your freeform button and it drops that black line right down to the green line, and boy, it looks great on the screen. Well, I can tell you that a 25 micron difference between the steep and flat meridian is not enough asymmetry to cause that lens to line up properly every time it's put on. So it looks great on the screen, but how are you going to guarantee that your lens is going to line up properly on that eye? So now, some days it lines up properly. Some days it may be 30 degrees off axis. Some days it's 60 degrees off axis. Some days it's 90 degrees off axis. And now your patient comes in and they're telling you that they're not really seeing consistently well. And you take a look at the maps, and depending on how you see the map that day, you might say, well, I don't see why you're not seeing well, or, oh my gosh, this is not lining up at all like how I expected it to. This is creating some under treatment or something like that. So now go ahead and design up another lens. And I'm assuming since you designed freeform the first time, you'll probably keep it in freeform the next time, and you will design up a whole bunch of lenses to solve a problem that you will never solve because the lens is not consistently performing each night. So that's just one example how freeform can mislead you down the wrong path here. There's elegance and simplicity, and if a freeform lens is necessary, I'm the first one to use it. But the vast majority of Ortho-K patients have normal corneas, and normal corneas can be very well addressed by an R-SIM lens or a G-SIM lens, which are much simpler lenses and will get the job done properly. So this is one of the reasons that you have to be very careful about I'll just design freeform on everyone because it looks really good on the screen.
Okay. And as far as the, so during insertion, if there's air being trapped under the lens, is there a way that you're seeing if that's happening and not another issue causing undertreatment?
I'm not sure what the question is. Is there a way I'm seeing it, or is the way the patient is seeing it?
I think if there is I think it's asking if there's anything coming up, maybe on a post-treatment map, or if it's just on lenses on the eye with fluorescein.
Gotcha. Okay. Well, if it's a consistent problem, And that could be due to a design issue as well, not just an application issue by the patient. They may be doing a good job, and maybe there's a design issue because there's excessive sag in one of the meridians out in the periphery there, and that's what's causing air to be pumped in there. If it's a consistent error, you will absolutely see that on the topography, because the topography will show that to you, and it will show you exactly where the air is creeping in. So that's easy to solve. The bigger problem is when the design is okay and the patient is just putting it on improperly. And if they're putting it on improperly, that's pretty hard to pick out from a treatment topography, unless it's really gross. I mean, it's an enormous thing, and you could see a split red ring or something. And the reason the split red ring is there is because there was an air bubble there all night. So unless it's dramatic, it's very, very hard to do that. To pick it out from the topography on the practitioner side. And so I really try and get the patient to put the lens on in the office if I do suspect it's an application problem, and I will watch what they're doing. And if I see that they're bouncing the lens around and losing solution on the way up to the eye, that's the first thing we're going to address, and we will make certain that they are getting it done properly. Now, one of the things that you can give the patient to do to check, there are two ways. The first one is if they tend to have good vision, and if it's kids, they tend to have very good vision, so they can pick up on it. If they look in the mirror, they can see what looks almost like frosted glass where the air bubble forms. And I will draw a picture so that they know where to look on the lens, because it's going to be in the reverse curve always. So if they see something that looks like frosted glass or like a steamy window type of thing, that's air. And so they should take it off and start again. Some of the air bubbles are a little too small to see, and they may not actually be able to pick up on that. However, as they get better, getting the lens on and more sort of experience with what the lens is supposed to feel like, if they're getting air trapped under it, the lens is generally a little more uncomfortable, and they can pick up on that as well. So those are things you can give the patient to do to make certain that they're not getting air trapped under there when they're putting the lens on.
Okay, that is great. And that is going to be our last question for the evening. And again, if some come through last minute, we can follow up via email. Thank you so much for your time, Dr. Mahler. That was great.
My pleasure. Thanks for everyone coming out tonight.
Yes, and thank you for everyone who attended and who asked questions. Just a reminder, we do take post-dispense cases at clinical support for WAVE. And that is going to conclude tonight's presentation. Thank you so much, everyone. Have a good evening.
Have a good evening. I'll see you soon.